Thanks very much. As you say, I've got years and years of experience, and the stark inequalities that really COVID-19 have exposed aren't new. I was a social worker in the early 1970s, first in Newcastle, then my home of Sunderland, and I witnessed firsthand the difficulties and challenges that face the most deprived communities in our country. I saw how the erosion of community institutions, of public services, that had become distant and unresponsive to local needs, and precarious and poorly paid work had left many families unprotected and isolated. And as we saw the decline of the industries that had made the Northeast, the coal mining, the steel making, the shipbuilding, particularly where I was working, so we saw many families unprotected and isolated. I also learnt that if deprived communities and the people in them are empowered to take decisions whilst given the right help and support, then the lives of the most disadvantaged in our communities can be transformed for the common good of all. I was therefore proud to be part of a government when I was a member of it between 1997 and 2007. We were able to empower disadvantaged communities across the country to begin to transform the lives of some of their poorer members and disadvantaged families. The introduction of the minimum wage, of tax credits, saw 800,000 children and 1 million pensioners lifted out of poverty. But central to those achievements was the reform of public services through programs such as Sure Start, and with a focus on health and family support, outreach and community empowerment. This was to really make sure that many children got a decent start in life. But despite our achievements, there remained individuals and families who saw little benefit from these policies and who were too often deemed hard to reach by public services. In 2006, I became Minister for the Cabinet Office and for Social Exclusion. And the Social Exclusion Unit and Task Force estimated that around 2.5% of the population were facing such multiple entrenched disadvantages that the government's reform agenda had actually hardly touched their lives. And this was why in September 2000, it was why I was appointed to the job to look at this, and why in September 2006, I launched an action plan on social exclusion. And the plan sought to improve and really focus on the lives of that 2.5% of the population. And we used really 5 principal issues that needed to be addressed. Deprived communities required better preventative services. How many times have you heard that? A system of identifying what works needed to be put in place. Better coordination of separate agencies was needed. And again, how often have we said that? But the right balance had to be struck between personal rights and responsibilities. And we found that people were often best supported by local voluntary and community groups, which helped them to help themselves and to gain control of their lives. And that's very much the territory that Amy was talking about. And finally, we needed to instill an intolerance of poor public service performance. 14 years later, and I now chair the Lords Public Services Committee. And that committee is currently conducting an inquiry on what coronavirus can teach us that can help us think effectively about public service reform. we found that many of these same structural weaknesses in models of public service delivery remain. COVID-19 has tragically demonstrated the consequences of leaving these issues unaddressed and of withdrawing support from some of them. Witnesses have told us how the funding of preventative services was not a priority in the years preceding COVID-19. Richard Sloggett of the Policy Exchange warned us that even in the midst of this crisis, we are still talking about short-term fixes, such as hospital capacity, rather than services that would prevent people ending up in hospital in the first place. Obesity was a significant health problem before the coronavirus outbreak and a symptom of our underinvestment in preventative services. And in England, about 27% of adult men and 30% of adult women are obese. And these obesity and associated diseases, such as diabetes, are concentrated in our most deprived communities. The fallacy of that idea that coronavirus is a great equaliser was demonstrated by that recent Public Health England report, which found that diabetes was mentioned on a significant number of coronavirus death certificates, particularly for BAME people. Diabetes was mentioned on 21% of death certificates, where COVID-19 was also mentioned. This proportion was 43% in the Asian group, 45% in the Black group, and higher in all BMA groups than for the white British population. Unsurprisingly, diabetes was also more likely to be mentioned on coronavirus death certificates in our country's most deprived areas. This same underinvestment is seen in adult social care. So James, who introduced this and talked about this in his introduction, and he told the committee that the severe budget restraints placed on adult social care in recent years has meant a reduction in preventative spending. Shamefully, this reduction in preventative social care has fallen disproportionately in the most deprived areas because, of course, there are more people in those areas who are reliant on public support from social care than in other areas. We've also been told by witnesses to our inquiry that going into the crisis, the national government too often did not take local expertise seriously. This lack of coordination between national and local agencies has played out with disastrous consequences during the crisis. Jessica Studdard, who is Deputy Director of the new Local Government Network, told the committee that during the early stages of the pandemic, local authorities did not receive information from the NHS about shielded groups, even though they were responsible for delivering food and essential supplies to them. So whilst many of the problems identified back in 2006 remain the same, some things have also changed, and sadly not always for the better. The 2.5% of the population identified by the Social Exclusion Unit as locked in a cycle of disadvantage and harm has grown exponentially in the last decade. The Marmot Review, published earlier this year, found that 10 years of austerity meant that people can expect to spend more of their lives in poor health. Improvements to life expectancy had stalled and declined for the poorest 10% of women. The health gap had grown between wealthy and deprived areas. Places matter. Living in a deprived area of the northeast was worse for your health than living in a deprived area in London, to the extent that life expectancy was nearly 5 years less. So Sir Michael Marmot, when giving evidence to the committee, told us that the stripping back of local government expenditure in the most deprived areas is likely to have made a huge difference in the 9 years since 2010. Spending in the 9 years since 2010-11, spending by local authorities went down by 16% in the least deprived 20% of areas and went down by 32% in the most deprived 20% of areas. He also described to us how the COVID-19 mortality rates in the most deprived areas are almost twice as high as those in the least deprived. But we've also seen other inequalities deepen during the pandemic. Again, a recent public health report found that the mortality risk from COVID-19 was higher among Black, Asian and minority ethnic people. The committee heard from the Angelou Centre, which works with BMA women in the Northeast, as well as Sir Michael Marmot, that the fact that Black British people and Bangladeshis have about twice the mortality rate from COVID-19 can largely be attributed to the deprivation caused by structural racism and deep-seated inequalities in health. We've also seen in recent years the structural problems in adult social care develop into a full-blown humanitarian crisis. This crisis has deep roots. Indeed, as Nick Pearce, who's now a professor but previously was head of the number 10 policy unit under Gordon Brown, articulately set out to the committee that the lack of integration and equality between health and care, which during the crisis was seen in the failure to have a proper testing infrastructure in place in community social care settings and for care homes, the discharge of patients from hospital into care homes without testing, and the lack of PPE, which ultimately resulted in thousands of unnecessary deaths, has its origins in 1948 and the foundation of the National Health Service, when medical care was made free, but social care was means tested. However, the committee has heard that going into this crisis, social care was facing unprecedented funding pressures and workforce challenges, with a vacancy rate of around 8%. There was a huge number of people living with unmet social care needs, including 1.5 million older people, according to Age UK. And as James explained to the committee a couple of weeks ago, those unmet needs have risen further during the pandemic, particularly among the working and the disabled, and the working age disabled. The social care bill has also rocketed during lockdown, threatening to cripple local authority budgets. The Health Foundation estimates that demographic pressures and rises in the national living wage alone will add £4 billion a year by the end of this Parliament and will require significantly more to address the sector's long-term needs. So this crisis therefore represents a risk and an opportunity. It has both deepened existing disadvantages, but has also forced into focus inequalities that have been with us for some time and that we have not significantly addressed. COVID-19 has removed any possible excuse for a delay in confronting these inequalities, and a radical reform of our public services, particularly social care, will be vital in achieving the levelling up of influence, power and opportunity which this crisis demands. As the experience of 1945 and the construction of the welfare state teaches us, times of national trauma can also give way to national renewal. What gives me particular cause for hope is the incredible innovation and civic action that we've seen, often at local level and on the front line, in response to the unprecedented demands that have been placed on public services and communities during this crisis. The committee has heard how local authorities, the voluntary sector, mental health services have collaborated in new ways during lockdown to support people with mental ill health at risk of homelessness and substance abuse to get themselves out of their difficulties and to gain control of their lives. Revolving Doors, an organisation that works with a variety of agencies to break the cycle of people facing multiple disadvantages, to make sure they don't end up in the criminal justice system. They told the committee that COVID-19 has resulted in unforeseen, sudden and large-scale changes to the services supporting people traditionally described as hard to reach. We heard how people facing multiple disadvantage have benefited from services becoming increasingly flexible during lockdown. The use of technology of fast-tracking and simplifying referral processes, increased collaboration between agencies under crisis conditions, and a reduction in bureaucracy had come together to transform people's lives. As one service user told Revolving Doors, more flexible ways of working during lockdown had given them responsibility and empowerment, which has been key to getting them on the path to recovery. So whilst the committee has received a fair amount of evidence on the overly centralised response to COVID-19, we've also heard how the crisis has resulted in local areas being empowered to support their most vulnerable members by taking a place-based approach to delivering integrated services. The NCVO and Lloyds Bank Foundation told us how increased flexibility in Cabinet Office commissioning guidance during lockdown, with a greater emphasis on social value rather than cost, has allowed local authorities to tap into the voluntary and community sectors in new and innovative ways when delivering social care and other services to meet local needs. And during the course of our inquiry, we've learned that if local areas are given respect and autonomy by central government and health, social care and other services treated as equal partners in a local system, then rapid integration and innovation for the benefit of local communities is possible. Eamon Boylan, Chief Executive of the Greater Manchester Combined Authority, told us how for years Greater Manchester had been attempting to have a single digital patient record to be shared across local health and care services. Within 6 weeks of the pandemic lockdown, it was done because the crisis demanded that local services were given the space to do it. However, this inspirational innovation, whether in commissioning, collaboration between health and social care, digital transformation and data sharing, the development of place-based approaches, or the new role for local voluntary organisation, this isn't enough on its own. A new funding settlement is essential. Eamon told us that Greater Manchester is facing a cliff edge in central government funding later this year. He set out the need for a frank discussion between national and local government about how services can be funded in the long term. And nowhere is this more necessary than in adult social care. The public desire and the political will brought about by this crisis to finally put into place long-term funding settlement for social care cannot and should not be wasted by the government. But another funding priority must be preventative services, particularly for our most deprived areas and disadvantaged groups, to stop people arriving at crisis point in the first place. Sarah Pickup, Deputy Chief Executive of the LGA, told the committee how cuts to preventative services in the last 10 years meant that going into this pandemic, our public services were fragile, struggling to cope with rising demand and health inequalities on the rise. And this left our most deprived communities particularly vulnerable to the virus. The government, even as it responds to to immediate needs of people pushed deeper into crisis during lockdown can no longer afford to ignore prevention and early intervention. And the historic problem of that being the first to be cut lives with us and has been so badly exposed. And Professor Marmot convincingly set out to the committee any long-term strategy for systematically reducing health inequalities and ensuring our service and communities are resilient in the face of future pandemics will require significant investment in preventative health and care services and a joined-up approach with housing, education, transport, early years and employment services. I hope that our report, likely to be published in October, when of course we could be facing we don't know what in terms of the virus, will continue to this new debate on public service reform. The innovations we've seen during lockdown cannot be lost. Services need to be given the political and financial support to be truly preventative and integrated to meet people's needs, and local areas need the means and autonomy to develop place-based approaches to support their most vulnerable. Just in the years following the Second World War, this crisis is an opportunity to reinvent our public services to make sure that they are fit to meet the challenges of our times. Thank you.
Well, thank you, Baroness Armstrong, for that. A really excellent distillation of the very many powerful voices that have given evidence to the committee, with the basic message that those structural deficits remain and there is still the need for investment and investment in prevention and indeed prioritisation in that investment. But from trauma can come innovation, but only with the funding and only where we enable localism. So that's fantastic. Thank you. Last and not least, Professor Michael Preston Chute. Now, Michael is a social work academic, I suppose I should describe him as, and is going to perhaps broaden our discussion again into how can social care respond to the inequalities and what should be the response of social care specifically. So over to you, Michael. Thank you.